Next slide, please.
Got it.
So as you guys, as everyone probably knows by now, the prostate is part of the, important part of the male anatomy. It sits kind of between the bladder and the urethra, the tube that comes out through the penis that urine runs through. The urine actually goes to the center of the prostate. So when we do a radical prostatectomy, we actually have to physically cut out the prostate and then sew the urethra and bladder back together. The function of the prostate does play an important role. Generally, when men are younger, it plays a role in kind of helping the semen liquefy and also contributes to part of the ejaculate fluid, the prostatic fluid that goes in as part of the, the ejaculate. Next slide, please. So prostate cancer is very common. It affects about 1 in 8 men in the US. It affects 1 in 6 African-American men. So it's a very common disease, one of the most common diseases we treat. And prostate cancer is traditionally diagnosed for men, anywhere from their 40s, 50s, but most probably commonly in the men in their 60s. And this comes in a whole variety of disease states, from very indolent prostate cancer, which will never kill you, to very aggressive prostate cancer that may affect their longevity. There is an estimated kind of 268,000 cases in 2022, but because a lot of men kind of live with the disease in the long term, there's actually 3.1 million men who are actually diagnosed and still living with prostate cancer in the US today. Next slide, please. So obviously there's multiple different risk factors. We know that if you have a strong family history for prostate cancer, it certainly increases your risk of getting prostate cancer. We generally recommend kind of screening earlier for men with a strong family history. As you get older, the risk of prostate cancer goes up. If we take a random population of 80, 90-year-olds who die for other causes, almost half of them may have prostate cancer, but they don't die from prostate cancer. It's from diabetes, heart attack, stroke, and other things like that. There's some thought that different exposure to chemicals, as well as, certain veterans or airline pilots have a higher risk of prostate cancer, and certainly race. We know that there's racial disparities in terms of kind of frequency of prostate cancer as well. Next slide, please. So there's kind of, one of the reasons we screen for prostate cancer is often there's no symptoms. I think, we do the digital rectal exam, or we used to do the digital rectal exam for primary care physicians, which was stopped recently given the kind of the lack of efficacy. PSAs, I'm sure you guys have remember, has been kind of in and out with the U.S. Preventive Task Force about whether we should be doing PSAs on men or not. But at the most kind of recent time point, we are still recommending PSAs for men, especially for men who are 55 and older. PSA is a blood test that basically allows us to screen for prostate cancer. Unfortunately, it's not a very specific test. There's lots of different reasons why your PSA can be high, which are unrelated to prostate cancer, including, inflammation or infection, or even sexual activity can kind of cause, elevated PSA. There's also other symptoms that we sometimes associate with getting older, which we see traditionally in something called BPH, or benign prostate hyperplasia. So a lot of these symptoms that we see here: urgency to urinate, waking up at night to urinate, pain with urination, hesitancy starting the urinary stream, or just having a weak urinary stream. A lot of this is probably more associated with benign prostate hyperplasia, not prostate cancer, but certainly some men can have elements of both. You can certainly have benign prostate cancer as well as, you can have benign prostate hyperplasia as well as prostate cancer. Some of the things that we do see in kind of very advanced prostate cancer, in terms of whether it's become metastatic, we see unexpected weight loss. We can get metastases to the bone, so we can see kind of pain in the pelvic area or the lower back. We can sometimes see anemia and fatigue, but this is generally a very advanced prostate cancer. And for the most part, as men who are getting routine screenings with PSA, this is less likely to happen. Next slide, please.
Can I ask a question? Can you hear me?
Of course.
So this is the blood in the urine. If someone who is in their 40s had blood in their urine, could that be something other than prostate cancer?
For sure. When generally blood in the urine for us is more commonly a symptom of bladder cancer. So someone comes and tells me, hey, look, I've got blood in my urine. We do a workup. We make sure they don't have kidney stones. They don't have bladder tumors, among other things. But prostate cancer to me is not when it high on the list of differential when someone comes in with blood in the urine.
I did, and they never tested me. And a few years later, I had prostate cancer, and there was never any kind of prostate cancer check when I had blood in my urine. So I had never correlated that as a symptom.
Yeah, for that one, to me, I think a lot of these symptoms that are listed on here are more related to kind of enlarged prostate rather than prostate cancer. But certainly some of these can contribute. An enlarged prostate can lead to blood in the urine and can also be a symptom of cancer, but generally less common.
Interesting. Thank you. Okay.
So things that we do to diagnose prostate cancer, obviously the PSA testing, something that's just a routine blood test that's done. A lot of times these are done annually with your primary care physician. If your PSA is elevated, generally you get sent over to see one of us. It used to be we would then just do a random 12-core prostate biopsy sample. Now the new guidelines and the new way kind of things have gone, we now get an MRI scan for the most part first to kind of see if there's any concerning lesions within the prostate. And that allows us to both sample the prostate as well as do kind of random samples of prostate as well as any concerning lesions seen on imaging. Kind of similar to most other diseases, we do imaging followed by biopsy. There's a few different guidelines for PSA testing, and we do certainly see men who have low PSAs who have prostate cancer, but generally, low PSAs, you're generally safe. But as your PSA starts to go up, and if it stays elevated or every year you get it checked, it goes up by a few points, then that certainly raises the concern for prostate cancer. Next slide, please. So, the good news with prostate cancer is there's a huge variety of treatment. Really depends on a few different kind of few different things depending on kind of the grade of your prostate cancer, whether you're low risk, intermediate risk, or high risk. And that helps me inform patients and kind of tell them what kind of options for treatment they have. For guys with low risk prostate cancer, I generally recommend active surveillance. This is basically not, we don't say good, see you later. We follow you closely. We do MRIs, we do biopsies to monitor, because we know about 50% of men with low risk prostate cancer can do just fine in active surveillance and may never proceed to treatment. But it is associated with some costs, right? So there's a physiological cost of, stress of living with prostate cancer. And there's also monitoring costs, MRI, biopsies, routine follow-up. For men with intermediate risk cancer and above, we talk about radiation and prostatectomy. These are the gold standard. This has been done for decades now. Radiation uses, X-ray.
What'd you
do?
It's frozen.
Yeah.
It's his connection, not ours.
Everything froze up.
Yeah.
Is from the outside to ablate to kill out effects of radiation. It's both long. You guys able to hear me?
Yeah, your signal seems a little weak.
Let me see. Kelly, can I log onto one of the computers here, you think? Let me try logging on to one of the computers and see if that may give me a better signal.
Okay, take your time.
I can always call in. Actually, let me call in. Actually, let me try this. Let me try calling into the meeting and see if that gives us a better signal. Let me do this. Yeah, let me try calling in and see if this works. All right.
All right, you gotta kill your other one.
Okay, how's that? Is that any better?
Yeah.
Okay.
So sorry, I'm dialing in. Sorry about the bad connection over here, but is everyone able to hear me a little bit better now?
Yeah, I think so. I think we're good.
Okay. All right. Sounds good. So, you know, I was kind of talking about radiation. Where did I cut off? Did you guys hear about surveillance, or did I get cut off before surveillance?
We heard surveillance when you started into radiation.
Okay, sounds good. So both radiation and prostatectomy have been treatments for prostate cancer. This has been around for decades. With radiation, basically, it's external beam or X-rays that are generated from a device that's used to kill off cancer cells. It can lead to, you know, short-term side effects as well as some long-term side effects from radiation. It involves anywhere from 5 treatments over 2.5 weeks to anywhere from 20 to 40 treatments, you know, over 1 or 2 months. Prostatectomy, also one of the things that we do very commonly, one of the most common procedures done in the U.S., associated removal of the whole gland as well as the lymph tissue around the prostate, or as the lymph nodes, but associated with some side effects of treatment as well. We can commonly see about 5 or 10% long-term risk of a urinary incontinence, as well as some erectile dysfunction in about, I'd say about 50% of men who have good potency prior. The recovery time generally is about 6 to 8 weeks. Well, certainly, it's about 6 weeks, but certainly most men are, you know, active and moving around right after surgery, as well as a whole host of kind of these more investigational procedures, something like cryotherapy or HIFU, laser, brachytherapy ablation, all the way up to Tulsa-Pro, which we'll talk about a little bit more detail. Some of these have been around for a long time, like cryotherapy and HIFU, which have been around for decades. And we have good 10-year, 15-year data, all the way up to Tulsa-Pro, which is kind of the newer kid on the block, which was FDA approved in 2019. Next slide, please. This slide is supplied by Profound, so it's a little bit biased. But you know, we used to do open prostatectomies, which we very rarely do anymore. Now we do robotic assisted laparoscopic prostatectomies, whole gland radiation. There's different types of radiation. They're both external beam. There's brachytherapy, which are the Cs, which a lot of people are familiar with. There's now also high dose brachytherapy, where they do needles in the operating room. They do 2 treatments. There's now an MR linear accelerator, which is MR guided radiation, which is very precise, and our radiation oncology colleagues are very interested and have been very excited about some of these new developments. And then there's Tulsa-Pro that we've been doing here at UT Southwestern since 2020, and have had a lot of patient interest that we can talk about down the line. Next slide, please.
Is the MR guided radiation, is that like proton or is that something different?
It's still, you know, it's still X-rays. It's not proton therapy. So I've had this conversation with our radiation oncologists why they don't offer proton here, and they basically say it's just fancy marketing. You know, it's more expensive. There's actually higher side effects to the rectum compared to traditional radiation, and it doesn't have any survival benefit or treatment benefit. So they just do regular radiation compared to proton. But it's, you know, most of it's CT guided, so they're not able to see the lesions nearly as well under CT. So MR guided, they're able to see the lesions and really target their energy to those lesions much better.
Fascinating. I am so glad you joined us tonight. This is great. Thank you. Oh, next slide.
So active surveillance, we talked a little bit about earlier, so I'm going to go through this relatively quickly. This is traditionally for men who have kind of lower risk symptoms, lower risk prostate cancer. So I generally recommend these guys for, you know, if you guys hear Gleason grade groups 1 or Gleason 6 disease, these are men who have disease that's confined within the prostate, and most of these men have low PSAs. For me, I follow these guys very closely. They get PSAs every 6 months. They get, you know, after their initial biopsy, diagnosing them with low risk prostate cancer, I repeat an MRI plus a biopsy at 1 year, because there's about a 30% chance of upgrading on subsequent biopsy, which will disqualify some men from continuing on active surveillance. This really has the least amount of side effects, right? There's no side effects for this treatment. There's no recovery. Men just continue living their lives the way that is, but oftentimes can be associated with some uncertainty as well as anxiety. And in one of the PROTECT trials, there was a slight higher risk of metastatic disease in men who did surveillance versus treatment, but overall we're still talking somewhere like 3 versus 6%. Next slide, please. Radical prostatectomy is, the surgery we do. I just did 2 of them today over here at the VA. So we removed the prostate, we removed the lymph nodes around the prostate. This allows us to look at the disease that's contained within the prostate as well as evaluate if there's any disease outside of the prostate in the lymph nodes. This has been done for a very long time, both open and now traditionally robotically. It's the only out of these modalities, the only one where we actually remove all the tissue and allow the pathologist to look at it. It's a surgery. It does take about 3 hours or so, 3 to 4 hours. We're doing these usually overnight hospital stay. We are starting to do some outpatient prostatectomies as well. Chance of erectile dysfunction does vary depending on where the cancer is, what your pre-op kind of erectile function is, but certainly can expect some temporary erectile dysfunction in majority of men that improves. I'd say probably about a 5 to 10% risk of urinary incontinence. I'm not quite sure where the 15% of GI toxicity came from in this slide, but traditionally side effects, urinary incontinence, erectile dysfunction of surgery. Next slide, please.
I had a question on the previous slide. It said removes the entire prostate gland and surrounding lymph nodes. Is that always done to remove the surrounding lymph nodes as well?
It's a good question. For the most part, we do. For men who have low-risk disease who elect for prostatectomy, we can sometimes omit lymph nodes because it does shorten the operation. There is sometimes a risk of removing the lymph nodes, including lymphocele and things like that. But we do see a 20 to 30% upgrade rate from biopsy. So traditionally, I will remove lymph nodes even for low risk because some of those guys come back with high-risk disease on final pathology, and you don't want to be kicking yourself that you'd never sampled their lymph nodes when they came back with high-risk disease after surgery.
Yeah, because if you took the prostate out, the lymph nodes that support it, do they serve any purpose?
Yeah, I don't know.
I don't
remember if they took my lymph nodes or not.
I know they did mine, or at least some of them. I don't know which one.
Yeah.
Yeah.
I just
For
about the lymph nodes.
So for most men, in your 50s or 60s are not actively trying to have children, the prostate really does not do much in terms of any kind of important function anymore.
Okay. Thank you.
So this is radiation. So there's a few different ways that they do radiation. The traditional ways, which is what's called image modulated radiotherapy, where it's under image guidance. This is traditionally 20 to 40 treatments. SBRT is one of the newer treatments. It's also called CyberKnife, some nice fancy marketing on their part. SBRT is 5 treatments, usually over about 2.5 weeks. This is for men with kind of low and intermediate risk prostate cancer. If you have high risk prostate cancer, generally this is not offered unless it's in a clinical trial. There's also proton therapy as well as brachytherapy seeds. There's been some very good developments in radiation oncology, and they have a very wide armamentarium for treatment of prostate cancer. Obviously, it's incision-free. There's no catheter involved, and kind of one of the benefits of radiation over surgery is that the risk of urinary incontinence is much lower with radiation. The side effects that we do see are kind of more, irritation to the bladder, irritation to the rectum, and we do see about a 5% long-term risk of damage to the bladder or rectum, which can sometimes be difficult for us to manage as urologists. We do see slightly better preservation of erectile dysfunction compared to surgery, maybe about 10% better, but some of these men do develop urinary incontinence down the line, especially a lot of the guys who've had brachytherapy seeds, which can be quite damaging to the urethra in the long run. Next slide, please. So focal therapy has certainly come around, and it's done in multiple other disease states. We do it for breast cancer. Radical mastectomy is no longer the first option for most women. They do, lumpectomy. If you come in with a kidney cancer, I rarely remove your whole kidney. I remove just the tumor and leave the rest of the kidney behind. So prostate is one of the few tumors that we still routinely remove or treat the whole prostate. So focal therapy really is the thought that, okay, I'm going to treat just the portion of the prostate where your cancer is. I'm going to try to leave as much of the rest of the prostate alone. I'm going to try to stay away from the nerves, the sphincter, to try to minimize kind of side effects of treatment as much as possible. So this has been kind of practiced and has been studied for 10 or 15 years now through a long variety of methods, starting from cryotherapy to HIFU to laser. And there's a few kind of downsides of focal therapy. I usually tell my patients there's a higher risk of cancer recurrence. I usually quote from all these traditional studies, somewhere between a quarter of men will have recurrent prostate cancer after treatment, and if we're being truly focal. The good news is that about 70% of those men can be rescued with another round of focal therapy if their cancer does recur. And for those guys who may not be able to get rescued by another round of focal, they can then go under surgery or radiation. So for my younger gentlemen, I say, look, we're not necessarily burning bridges for other modalities down the line. And for those who prioritize functional status over cancer control, I think focal therapy is a reasonable option for some men. Again, this is probably not for your men with high-risk prostate cancer. I traditionally think this is probably best for men with low to intermediate-risk prostate cancer. Next slide, please. So HIFU is one of the ways of treating prostate cancer that's been around for about 10 or 15 years now. Certainly the newer technologies have gotten a little bit more computer guided and robotic guided. It's a procedure where ultrasound transducer is placed in the rectum, and it focuses ultrasound waves through the rectal wall into the prostate. It can certainly target multiple parts of the prostate, so sometimes anterior prostate or the prostate furthest away from the rectum can be harder to reach, and the treatment efficacy in the anterior prostate can be a little bit more challenging. You do get some of the side effects of HIFU, just like Tulsa. You can get more frequent urinary urgency and frequency, small risk for urinary incontinence, as well as erectile dysfunction or recurrence of cancer. Next slide, please. Sorry. Cryotherapy has also been around for quite a long time. This actually, I think, was first done in the 60s, actually. But the way we traditionally, we now use cryotherapy in the focal sense is we're very kind of focused in how we apply the energy. Unlike HIFU, which uses ultrasound to heat up the prostate to kill off prostate tumors, cryo uses a mixture of gases that basically forms an ice ball within the prostate and kills off tissue that way. It's an outpatient procedure. You go home with the catheter usually for about a week. Also, it allows us to repeat the procedure as necessary. Has some risks in terms of, some men get swollen scrotum, they have perineal pain, they can have small risk for infection. And there used to be a lot of horror stories from cryotherapy when we used to freeze the entire prostate and cause, lots of erectile dysfunction and urinary incontinence. But traditionally now, the way we do it in terms of true focal, we rarely see those side effects anymore. Next slide, please. So Tulsa, I'm going to talk a little bit about the Tulsa procedure, which is, I think, the point of this today, as well as, the benefits or risks of the procedure, who makes a good candidate, where we can get the procedure. Next slide, please. I think this may be an animation.
The Tulsa procedure is a new solution for men with prostate disease, including prostate cancer and benign prostatic hyperplasia, or BPH. It's a minimally invasive treatment that is incision-free, radiation-free, and performed in an outpatient setting, meaning patients go home the same day as the procedure. TULSA stands for transurethral ultrasound ablation. Transurethral because the device reaches the prostate by entering the urethra. Ultrasound because ultrasound energy is used to heat the prostate tissue, and ablation because the heating is used to precisely destroy the targeted tissue. The Tulsa-Pro system uses real-time MRI, which provides a clear image of the prostate, disease, and surrounding anatomy. Tulsa-Pro offers a gentle heating pattern, which ablates desired prostate tissue while cooling the rectum and urethra. The physician can choose to ablate the whole gland or ablate portions of the gland, known as focal therapy. The Tulsa procedure ablates the prostate from the inside out, from inside the urethra, feeding outwards to the edge of the prostate. Tulsa is an MRI-controlled, robotically driven procedure delivering 1 millimeter ablation precision to avoid critical structures and help preserve man's urinary, sexual, and bowel function. Based on recent trials, 98% of men with prostate cancer who had focal therapy with Tulsa reported preservation of erectile function and urinary continence and were pad-free at 1 to 2 years. FDA clinical trials of the Tulsa procedure for whole gland prostate ablation in men with prostate cancer reported preservation of erectile firmness sufficient for penetration, proving to 87% during 4-year follow-up. 99% of men preserved urinary continence at 1 year, which was durable with 4-year follow-up. There have been over 3,000 Tulsa procedures performed worldwide, and over 20 clinical publications have been published, some including 5-year outcomes. The Tulsa-Pro system is FDA cleared for the ablation of prostate tissue. Physicians have prescribed the Tulsa procedure for patients with primary prostate cancer, whole gland or focal, BPH, and salvage ablation for radial recurrent prostate cancer. If you are in need of future prostate care, you may either have a repeat Tulsa procedure.
So Steve, I think we can probably skip on to the next slide, and if people want to watch the full video, they can at a later time. So like the video mentioned, this is the Tulsa procedure is done through a transurethral ultrasound device. So it's different from HIFU, which the energy is directed from the rectum to the prostate. This is how the energy is directed from the urethra out. So we think that there's less risk of rectal injury. There's a rectal device that cools the surface of the rectum at the same time. It is done under MRI guidance, so it gives us very good, concise, precise control and feedback in terms of how much the temperatures within the prostate are, as well as how much our ablation and is going. So in terms of amount of feedback and amount of information I get from the treatment, this is probably one of the top methods of doing focal therapy compared to some of the other modalities out there. Next slide, please. I think we can skip the next slide. I think the video mentioned some of this stuff. It's outpatient procedure. It allows us to treat both a small area of the prostate or up to the whole prostate. There was a TAC trial, which was the FDA-approved trial, where the FDA trial that led to approval of the Tulsa device back in 2019. This was about 100, a little over 100 men were in this trial. This was whole gland. This was not focal. So this was treatment of the entire prostate. You can see preservation of erectile function was good in men who were potent prior, as well as continence was preserved in men, quite well. The downside of this initial kind of treatment was that it was only a single pass, so we did see cancer, recurrent cancer in about 20 to 30% of men in this trial. The Ulta is also another looking at kind of more focal therapy. This is not whole gland, this is focal therapy. So as expected, we're treating a little bit less of the prostate. We're staying further away from some of the nerves. So preservation of erectile function and continence are quite good. And one of the things that we have seen rarely with HIFU, I'd say probably less than 1%, is rectal fistulas, which is a complication where you can form a connection between the rectum and the prostate and can be difficult to manage. As of yet, we have not had any reported instances of this with Tulsa. Next slide, please. So the Tulsa procedure is done, this is the kind of the workflow when you guys come in. Patients will go under general anesthesia. You'll be fully asleep for the procedure. We're then brought into the MRI room. They're positioned in the MRI machine where we place the devices through the urethra, through the rectum that allow us to both deliver treatment and monitor. We then run an MRI sequence to re-image the prostate. And the nice thing is this is essentially what your prostate looks like on treatment day. We're not kind of using prostate MRIs that may have been obtained a few months ago. We then kind of map out our treatment based on this kind of real-time imaging, and then we deliver the energy. The treatments last, depending on how much prostate tissue we're ablating, anywhere from 30 minutes to about 2 hours. This is under computer guidance, meaning that we can see the temperature maps, and the robot rotates 360 degrees and kind of fires ultrasound beams outwards. At the end of the procedure, we then obtain a contrast-enhanced MRI. This basically allows us to see which areas of the prostate we've essentially devascularized and killed off, and gives us a good sense of how successful we think we were during the procedure. Next slide, please. So in terms of kind of post-op care, we certainly send men out with medications. We send them with about a week of antibiotics. We send them with medications to help with swelling of the prostate, because you can imagine if we heat up the prostate will swell. So we will usually give them about a month of medications to help them urinate. Catheter duration, depending on the extent of treatment, is anywhere from about 5 days to 2 weeks. If I treat the whole prostate, I'll usually leave a catheter for 2 weeks, as some of these guys will have trouble urinating if the catheter comes out too early. Unlike surgery or radiation, where the follow-up is much more simple in terms of just blood tests, because we are still leaving prostate tissue behind, there's a higher chance of cancer recurrence with these procedures compared to surgery or radiation. I follow these men very closely. We do PSAs every 3 months for the first year. I mandate an MRI plus a biopsy at 1 year to make sure there's no residual disease, and I probably do annual MRIs for men to make sure that we catch any recurrences early if they do recur. Recovery time, for the most part, most patients bounce back pretty quickly. Most patients take it easy with the catheter in place. Once the catheter comes out at 1 or 2 weeks, they start resuming normal activity. The most common complaints I get from patients are that they have increased frequency urgency for the first 4 to 6 weeks, generally from the inflammation from the procedure and the swelling of the prostate. I do get some urgency incontinence, meaning they have the urge to urinate. If they don't make it to the bathroom in time, they will leak a little bit. Generally, that improves once the inflammation goes away at 4 to 6 weeks. Other than that, by the time I see these guys at 1 month, a lot of these guys are kind of getting back towards their baseline function. Next slide, please. I'll leave you guys with some testimonials to read later. Next slide, please. So which men are candidates for Tulsa procedure? This is a good question that many people are interested in. Generally, these patients come with 2 ways. One, they'll come to see me directly for newly diagnosed prostate cancer, or they'll hear about the Tulsa procedure and come to us through radiology. They'll see the radiologist first, and then they'll come see me. It's a team approach here at UT Southwestern where the procedure is done with both a urologist and a radiologist during the procedure. 2 things. One is you have to be eligible for magnetic resonance imaging for MRI. If you have shrapnel, if you have an implant or some sort of other devices that's not MRI compatible, unfortunately, this procedure is not good for you. You have to be healthy enough to undergo general anesthesia. And obviously that carries its own set of risks for undergoing anesthesia. We do have to do some anatomic screening if you have a urethra that's too small, if you have prostate calcifications that are too big, or cysts, which are fluid-filled kind of pockets within the prostate. If those are too big, those make you ineligible for the Tulsa procedure. And for those guys, I generally talk to them if they're very interested. So in focal, I have a whole kind of other modalities for treatment of prostate cancer that sometimes are independent of calcifications. Obviously, like we talked about, if you have implants, makes it difficult or rules you out as a candidate, or if you have metal fragments. Next slide, please. So that's lots of places that are offering Tulsa. Here in Dallas, we offer it. We're probably one of the higher volume places in the country that's offering Tulsa right now. I think we've just reached 109 patients. We do generally about 6 to 8 a month. We also offer, prostatectomy, radiation here, as well as a few other focal modalities, include irreversible electroporation. But if you go to the Tulsa-Pro website, you can see all the different locations that offer Tulsa. Slide, please.
If someone went down to Dallas, they need to be there for a couple of weeks and then they could come back home. Is that about right?
No. So I've treated patients from all over. I've treated patients from Hawaii and, or from Amarillo. These guys will come in for their treatment and they sometimes will stay a day. Sometimes they'll go back home to where they are the same day. Generally, if you're out of town, I say, look, stay in town for a day or 2 before you hop back on the plane just to make sure you're feeling okay.
Okay. So the follow-ups can be done, like on a
I usually see patients 1 month out. A lot of times the local urologist will help us out, take out their catheter locally, save them a trip in, 1 to 2 weeks out. I do like to see everyone in person at 1 month. Unfortunately, with some of the new rules, I can't do telehealth visits outside of the state of Texas anymore. We were able to during COVID, but they got rid of that exception. So I'll oftentimes rely on the local urologist to help with some of the monitoring for PSAs, and then I'll see guys at 6 months and usually at 12 months for MRI plus biopsy.
Yeah, so I didn't say that. I don't ever like, I'm just a volunteer. I do computers, not medicine, and I'm not trying to offer any advice. We put all this stuff together, but I wanted you guys to know about this. And then this is like something that just literally happened yesterday. I had a person who runs, it's called Angel Flight, contact me, and they're going to do a little 10-minute presentation next time, and they're offering free flights.
Nice.
Yeah, so I just, when you were talking about that, I was like, thought, well, it got me thinking, so, yeah, all right, I'll turn it back over to you.
So I think that's it. I got, in terms of my slide deck, if you guys have any questions, I'm happy to kind of answer whatever you guys have.
Thank you so much for sharing this. I've heard about people traveling for these things and just hadn't ever talked to anyone who ever had done them before, so thank you. It looks like we've got some people online. Anybody want to ask some questions while we still got the doctor with us? You're muted, by the way. Feel free to unmute. Anybody in the room?
Oh, no, I'm good.
My question was, you talked about they use this procedure for salvage radiation sometimes for if you've had radiation failure, or was I confusing it with something else earlier?
Nope. So certainly we've been doing this for, more experimental fashion for men who have failed radiation, meaning, they've got radiation, a few years down the line, their PSA starts to rise, we biopsy them, we find residual cancer. We've done this I think we've done it in 8 men so far. The majority of these men have done quite well after this. I do actually like this for the salvage setting, because doing surgery after radiation is very challenging. A lot of times it's very difficult to preserve continence. I usually quote men somewhere between 20-30% chance of long-term incontinence after salvage prostatectomy after radiation, as well as preserving erectile function. So certainly the guys I've treated with this, it's not been perfect. There has been some guys who do have urinary incontinence, who've had prior radiation. But the short-term data, has been good. I'm waiting for some of the long-term biopsy data for these guys to start hitting the 1-year mark. But the PSA responses have been nice after this, and I think it's actually not a very nice way of, being less aggressive in terms of treating cancer that comes back for men who've had radiation before.
Thank you.
Anyone else online? Well, let's everybody say thank you. This is a big fan. Thank you so much for joining us.
Of course, happy to.
Recording.